Hello, my name is Angelique Johnson, and I'm a PhD student in the Department of Nutrition and Dietetics at Florida International University. I'm also an HIV and AIDS nutrition researcher. Today, I'm going to be speaking about HIV and AIDS in Botswana, Africa. HIV stands for the Human Immunodeficiency Virus. HIV is exactly just that, a virus which attacks the human immune system. Your body contains billions of white blood cells that help fight off infections. Very important white blood cells called CD4 leukocytes are extremely attacked by the HIV virus, making it difficult for you to get over infections in the future, which could potentially be deadly. AIDS, or acquired immune deficiency syndrome, is the final and most severe phase of HIV infection. People living with AIDS have such poor immune systems that often they suffer from severe illnesses known as opportunistic infections. There is currently no cure for HIV or AIDS, so once you're infected for life. As a result, this has become a global public health problem. In 2015, 2.1 million new infections were reported around the world, totaling up to over 36.7 million people worldwide living with HIV and AIDS. This is the equivalent to the entire population of the city of Tokyo in Japan being infected with HIV at the same time. The same year, 1.1 million AIDS-related deaths were reported. Unfortunately, this virus affects different groups unevenly throughout the world. Some of these at-risk populations are women, children, men who have sex with men or MSM, migrant workers, and those who engage in sex work. Botswana is a country located here in the southern part of Africa. It is a middle-income country with almost 2.3 million people. The problem? 22% of those people in Botswana are living with HIV infection, making it the country with the third highest prevalence in the world. In 2015 alone, 9,700 new infections were reported, and of the 2.3 million individuals living in Botswana, 350,000 of them are currently living with HIV and AIDS, as well as 3,200 deaths being reported related to HIV and AIDS. So these two graphs help to show not only the high prevalence of infection in the African continent, but also the high prevalence found in Botswana as compared to other neighboring countries. On figure 1 on the left clearly demonstrates that Botswana is among the top 3 for HIV prevalence in Africa. And figure 2 on the right demonstrates the high proportion of each country's population that is afflicted by this terrible condition. As years pass, you can see how the darkening of the red not only demonstrates how badly southern and eastern Africa are affected, but also how quickly rates of infection can increase. I've included this chart, however, to bring up a very interesting point regarding Botswana and its HIV epidemic. You can see here by the gray circle that Botswana has 350,000 people living with HIV and AIDS. The number 1 and number 2 countries for prevalence, Swaziland and Lesotho, have fewer members of their population infected. So why isn't Botswana number 1 for HIV prevalence? In the next 3 columns, you can see that both the top 2 countries in 2015 experienced high rates of new infections, AIDS-related deaths, and also had low patient adherence to antiviral treatment. However, in Botswana, in each of these 3 categories, Botswana prevailed as it saw lower rates of new infection, AIDS-related deaths, and more adults being treated with antiretroviral treatment. This goes to show that a country's efforts to increase treatment and improve prevention can actually go a very long way. In Botswana, the northeastern part of the country is more afflicted by HIV. Cities like Francistown, Selabipikwe, and Sao experience prevalence rates of up to 66%. This is particularly a result of a high population of migrant workers in these areas, as Botswana has attributed most of its wealth to precious stone mines. When these laborers go off to seek work, they subsequently leave behind their wives for extended periods of time. This prolonged separation increases the use of services by sex workers. However, the major problem is that this is rapidly spreading the disease, as many men are being infected by infected sex workers, are not realizing that they are being infected, and then returning home and subsequently infecting their unsuspecting wives. In 2013, the prevalence of HIV in women was 20.8% as compared to men, which was only 15.6%. In 2015, more than 190,000 women were reported living with HIV and AIDS in Botswana. That's more than double the amount of men. Mother-to-child transmission of HIV is also of great concern, as infants can become infected through the mother. However, successful prevention interventions implemented in Botswana has reduced this rate to a mere 1.8%. I've included this graph, this chart, to show up a very interesting point regarding, So HIV prevalence in women continues to rise, but for reasons that we'll talk about in a little bit. In the meantime, this graph helps to show provide a visual representation of how the incidence of HIV in women in Botswana has been increasingly steadily for almost 30 years. So back to disproportionately affected populations. Those who are homosexual also suffer from disparate rates of HIV infection. In 2015, 13.1% of those infected men with HIV in Botswana were men who had sex with men. The provision of services to this population is very difficult as a result of homosexuality being outlawed in Botswana. Although criminalizing homosexuality obstructs progress within this group, members of the Botswana government are still aware of this population and openly discuss the importance of targeting the population with specific HIV prevention and treatment. Another population that's heavily, unevenly affected by the disease are those who work in sex work. In 2015, an estimated 4,000 female sex workers were living in the country. And currently, Botswana does not have any specific approaches directed towards helping female sex workers. Despite stigma against homosexuals and other groups, Botswana's reaction to HIV has demonstrated some of the world's most impressive results. Botswana was the first African nation to offer art, and more money made from those precious stone mines means more money to put into HIV/AIDS surveillance, treatment, and prevention. The first AIDS case reported in Botswana occurred in 1985. Between 1987 and 1989, Botswana mostly concentrated its efforts on screening donated and stored blood in order to reduce the risk of infection from blood transfusion. From 1989 to 1997, prevention and intervention plans began to introduce data, training for staff, and coalitions with other programs in an attempt to reduce the HIV prevalence. Early responses to this epidemic were less than enthusiastic. So in 1997, these programs also began to implement training, prevention, and education, as well as complete care for patients that did also include ART treatment. So the National AIDS Council Agency, or NACA, was founded in 1999 under the National AIDS Council. This organization sought to increase national mobilization and response to the HIV/AIDS epidemic, and recruit stakeholders from the government and private divisions, as well as environmental health and economic sectors. It really wanted just to get everybody who's important involved. So Botswana highly encourages comprehensive sex education that includes HIV prevention strategies in secondary schools. This is actually a very good thing because most countries actually don't make sexual education mandatory in their school curriculum. It is really important that young individuals are furnished with HIV training very, very soon on. So that way it'll help shield them from contamination later on once they do become more sexually active. Programs such as the Youth Health Organization, or YOHO, have helped to educate adolescents about HIV through art, events, shows, and group conversations and presentations. The Ministry of Education of Botswana, together with the United Nations Development Program, has also been credited with creating programs that help to educate healthcare professionals, and as well as use social advertising and other marketing techniques to expand condom use throughout the nation. The Lovers Plus condom and the Care female condom have been promoted by the company PSI, or Populous Services International, since 1993 and 2002, respectively. One of their main approaches has been to market condom use using peer-to-peer instruction in a variety of settings, such as schools, office buildings, malls, and even pubs. So in 2003, the African Comprehensive HIV and the African Comprehensive HIV and AIDS Partnership, or ACHAP, as I like to call it, with the Botswana government, propelled a widespread condom dispersal and distribution effort. As a result, over 10,000 condom machines were installed in both conventional and non-conventional locations throughout Botswana, making millions upon millions of condoms available to the population at complete free of cost. Here we go. Oh, here we go. What happened here? There. So these photos are an example of advertisements for the Lovers Plus and Care brands of condoms that have been advertised in order to increase HIV prevention. So through the combined efforts of organizations such as the Safe Blood for Africa Foundation, the Ministry of Health, and also ACHAP, Botswana has improved in their safety of blood used for transfusions. So the country adopted the World Health Organization's practices and procedures for screening blood, which did include the barcoding of samples and also using electronic computer software to test the blood in order to reduce the risk of transmission due to errors in human testing. So the prevention of the infection via transfusion was further reduced by such programs such as the Blood Safety and Youth HIV Prevention Program that was made in 2003. This program was also known as Pledge 25, and its purpose and basically where the results stemmed from was that it enlisted young adults and asked them to please donate their uninfected blood to hospitals and urged them to donate a minimum of 25 times throughout their entire lives. So a direct outcome of this program was seen in 2006 with a 5.4% decline in the rejection rate of blood due to infection. And this was mostly as a result of the Pledge 25 program and its incorporation of a lower risk population to donate blood. So reducing the transmission of HIV from mother to child was one of the main focuses in Botswana for their first ever antiretroviral therapy program. So without access to ART, approximately 33% of the infants that are born to mothers that are affected with HIV will also become infected with HIV either during pregnancy in the third trimester, during delivery, or through breastfeeding. However, even though Botswana began implementing these programs, originally only 11 to 20% of women actually registered for the program as a result of under-organization and not enough people to staff the program. But low enrollment didn't stop policy and program makers, mostly because, oops, I'm sorry, my computer is doing something strange. I apologize. Here we go. So low enrollment didn't stop policy and program makers as endeavors recently increased, and in a very, very significant way. Numerous organizations have been founded through the Maternal, Child, and Health Family Planning Framework. So much so that in 2014, the program was available in 634 health facilities only 1 year later. And 92% of all pregnant women in Botswana were receiving antiretroviral therapy. These efforts have helped to reduce the percentage of mother-to-child transmission to a measly 1.8%. So routine HIV treatment, routine HIV testing has been offered as a normal part of medical checkups in clinics, both private and public, throughout Botswana since 2004. The issue, I'm sorry, I just lost myself. Here we go. Here we go. Since 2000, Botswana government and the Centers for Disease Control and Prevention have advocated and encouraged the use of the Tebelopele system of voluntary counseling and testing, or VCT. So the service helps to provide free, private, anonymous, same-day testing for sexually active adults between the age of 15 and 49. Between 2000 and 2004, Tebelopele offered services to 234 people living with HIV. And by October 2005, the program increased to 16 health centers, 8 satellite locations, and had given free VCT to over like 72,000 people or something. It's fine. Oh my gosh, what is going on with this computer? I apologize. Did I just stop? Okay. I apologize. How's this ever going to go on YouTube? It's just like so difficult. How do people do this for like a living? All right, so routine HIV testing has been offered as a normal part of medical checkups in clinics, both private and public, throughout Botswana since 2004. Botswana was the first nation in Africa to execute a national routine HIV testing policy into its clinics. And as a result, in the first half of 2005, over 74,000 individuals were tested for HIV through the program. Health officials consider this routine testing to be an efficient way in order to lessen the burden of hospitals because of patients that are suffering from the conditions associated with not being treated or being in later stages of the disease. And it also helps to reduce stigma that surrounds testing and the disease, because if testing is just made to be as something normal, then more people would seek it out because they aren't scared of the repercussions from being found out. So towards the end of 2000, the then president Festus Mogai stated that the new funds that had been donated by HAP would enable the distribution of ART to all pregnant women and children who were infected with HIV. So during March of the following year, it was announced that a new national treatment program, later given the name MASA, would be realized by the end of the year. A needs assessment was conducted by the Botswana government in order to create a program that would help to facilitate longer and healthier lives for those that were infected, also help to offer incentives for getting tested, and reduce the number of children that are left orphaned because of HIV and AIDS-related deaths. By the start of 2002, MASA's goal was to distribute ART to 17,000 of the 110,000 affected individuals living with HIV. But due to insufficient resources, space, personnel, and organization, the program began by targeting only 4 very specific populations. That included HIV-positive children, pregnant women, HIV-positive individuals that were also co-infected with tuberculosis, and inpatient adults with AIDS. The very first ART medications were distributed in January of 2002 at the Princess Marina Hospital in Gaborone, which is the capital of Botswana. By mid-year, 871 adults were registered in the Massa at Princess Marina Hospital program, and by September of 2005, which was only 3 years later, over 54,000 adults and over 4,000 children were treated for HIV. So, the goal of achieving a perfect treatment system in Botswana is far from being reached. So many individuals are still dying due to lack of treatment, and those currently receiving treatment are required to continue this treatment for the rest of their lives. So taking a medication every day and adhering to this regimen every day can be exhausting and daunting, even for somebody who's healthy. Imagine how difficult it is for these individuals who don't have energy, can't eat, are vomiting, and are dealing with all sorts of stigma as well that lower the self-efficacy to go seek help. So the distribution of treatment is considerably less demanding in municipalities and in rural regions. So MASA needs to disperse their reach quickly in order to guarantee that they reach everybody who's being afflicted by the HIV epidemic. Another really important thing that hasn't happened in Botswana is that we need a noteworthy women's movement. And with no formidable progress being made in the direction of equality for women, women will continue to have very little say in politics and health policies. So in 1995, the country offered like a shallow attempt at a women's movement, but it ended up just being a bunch of the wives of these government officials, and they would just get together and discuss how to be better wives. The socioeconomic gaps that are experienced by women in comparison to males results in a lack of education on prevention strategies, and consequently, the need to succumb to societal expectations and pressures. So in contrast, other African countries that do allow female participation in government positions, such as Uganda, they've passed laws that actually help to strengthen women's health and to protect women from HIV. So this lack of female empowerment in Botswana and a lack of interest in the education of females makes women in Botswana more susceptible to the infection. Not only are these women more at risk because of the natural anatomy of the female genitalia, but also because gender inequalities expose them to violence, rape, child marriage, and an inability to make safer sexual decisions because of a lack of knowledge regarding HIV prevention methods. So prevention programs for homosexuals are not encouraged in Botswana, and laws exist that forbid same-sex activity, punish homosexuals, and also increase the stigma that's associated with homosexuality and HIV. In Botswana, homosexuality is often referred to as a disease, causing these individuals to be shunned by their friends and families. Thus, studies focusing on homosexuals in Botswana are often ineffective and underestimate the true prevalence among this population, as most individuals will not admit that they are gay or engage in homosexual sexual acts, but they also fear imprisonment and fines should their homosexuality be revealed to other public officials. So this perpetuates the spread of the disease and increases the number of individuals who die every year because they're not seeking treatment. Okay, so prevention programs for, here we go. Now we're going to talk about migrant workers. So due to variances in health policies, these migrant workers also experience a lack of accessible health resources due to economic changes or the reduced availability of medical care. Migrant workers are actually forced to pay for their medical care, whereas everybody else in Botswana gets free health care, especially when it comes to free, antiretroviral treatment to help keep them healthy. So in 2014, the Botswana Network on Ethics, Law, and HIV and AIDS, which is a human rights group, they basically sued the Botswana government, saying that it was unconstitutional for them not to provide this free care to those in need, specifically to migrant workers and prisoners, and that they should be given it free of charge. So the group won, but the Botswana government actually intends to fight the ruling, which further adds to the difficulties this population must endure. So again, we also have to remember that the wives and partners of migrant workers are also unknowingly being put at risk because of the increased use of services provided by sex workers. Wow, and that's it. We're done for the day. Thank you so much. And I really hope that you enjoyed it and that you learned something. If you have any questions, or if you have any interests, or if you just want to leave me a comment, go ahead and leave me a comment in the notes below. And thank you so much for listening to my presentation. Have a great day.